Good evening and welcome to HFA's Blood Brotherhood webinar series. My name is Lauren Nybert and I am the Associate Director of Programs for the Hemophilia Federation of America. Also joining us tonight is Elaine Shan, HFA's Program Coordinator. Thanks for taking the time to join us this evening. We really appreciate you all being here. Before we get started, I'd like to go over a few webinar tips. Tonight's webinar will last approximately 1 hour, and we certainly welcome your participation and questions. However, your audio will be muted during the entirety of the webinar, as this helps limit background noise that may disrupt the presentation. If you have a question, we encourage you to type it into the question box at the bottom of your control panel. I will then pass these questions along to our speaker. HFA would also like to thank Baxter and our CDC collaborative partners for their support of HFA's Blood Brotherhood program. So tonight's presentation is Managing Arthritis with Hemophilia, Prevention and Treatment. I'd like to introduce our presenter this evening, Dr. Annette von Dryglaski. Annette von Dryglaski is the Assistant Clinical Professor of Medicine in the Division of Hematology Oncology and Director of the Hemophilia and Thrombosis Treatment Center, Department of Medicine at the University of California, San Diego. She is also Adjunct Assistant Professor, Department of Molecular and Experimental Medicine at the Scripps Research Institute in La Jolla, California. Dr. von Dryglaski is board certified in hematology, oncology, and internal medicine. She is a member of the American Society of Hematology and the World Federation of Hemophilia. Dr. von Dryglaski is dedicated to the care of patients with hemophilia and other bleeding disorders. In this role, Dr. von Dryglaski developed basic translational and clinical research interests addressing the evolving needs of aging patients with hemophilia, such as cardiovascular and joint disease. Dr. von Dryglaski is the institutional principal investigator of several international clinical trials exploring long-acting or novel clotting factor products, as well as studying hypertension and joint disease in patients with hemophilia at the bench and in clinic. So with that, I'll turn it over to Dr. von Dryglaski. Thanks for joining us tonight to provide this important presentation.
Well, thank you everyone for spending your Monday evening with me and discussing managing arthritis for adult men with bleeding disorders, prevention and treatment. And we hope we will have a stimulating and good discussion at the end, and any questions you have, please ask. So hemophilia and arthropathy. We talk about arthropathy and use this name frequently. What is it? It's just another word for joint disease. And so what is the arthropathy burden that we so often talk about? To set the stage, we all know, and especially you do know, that hemophilia presents with spontaneous joint and muscle bleeds, and those have detrimental consequences. In severe hemophilia, it's been published that if no prophylaxis is administered, the median number of bleeds per year can be as much as 45. In that sense, as a consequence of bleeding, hemophilic arthropathy originates, and it is a debilitating condition. Especially in adulthood, in patients with severe hemophilia, it has been shown that about 60 to 80% of young adults, age 18 to 40, might have dysfunctional joints. And then on top of that, the development of inhibitors is a devastating complication and increases the burden of arthropathy even more. So this is just, again, to set the stage and to show you intraoperative findings in hemophilic arthropathy. And these pictures date back 30 to 40 years ago, when there was no treatment and patients needed surgery to remove what you see here, hemosiderin-laden synovium black from all the bleeding and the iron depositions. And then in this photograph here of an X-ray, you see that all the joint space is in essence gone. So hemophilic arthropathy, there are many open questions, questions that we don't always have an answer for and need to now follow, especially aging patients, to do new research. So, for example, does joint bleeding change over a lifetime? In other words, could it present differently in a child from someone who is adult? what is hemophilic arthropathy exactly? How many joint bleeds can one experience without lasting damage? And what can we do in the end as providers and you as patients to prevent and treat? So let's tackle them one by one. Does joint bleeding change over a lifetime? Probably so. In infancy, as you all may very well remember, joint and muscle bleeds occur at first onset of walking, and for some curious reasons, joints most prone to bleeding are knees, elbows, and ankles. And there is this terminology of a target joint, and that is defined as a joint that suffers, let's say, from a few bleeds over a short period of time. In youth, bleeds are mostly facilitated by growth spurts and also physical activity. We still call them spontaneous bleeding, but if we think what our young people do nowadays, they might not be all that spontaneous. And then in adulthood, the picture becomes a little blurry. Joint bleeds, yes, but there's also scarring, deformities, burnout arthropathy, and very often this question of subclinical bleeding comes up. Subclinical bleeding, there is blood in the joint without necessarily causing prominent symptoms. So in my practice, I mostly see adults with a bit of a blurry picture, and keep that in mind because this is where the talk is going, and this is probably where most of you are currently. So what is hemophilic arthropathy? It's not really well defined. It's a compilation of findings. Some are similar to osteoarthritis, which is a degenerative, globally speaking, a degenerative joint disease of aging with cartilage destruction. Some findings are similar to rheumatoid arthritis, which is really an autoimmune disease, a systemic inflammatory disease, but with lots of synovial hypertrophy and inflammation in the joint. Some findings are similar to injuries in sports medicine, and some just don't fit any known pattern at all. And by the way, a little bit of terminology. Itis means inflammation, and if something has an osis or an arthropathy, it more alludes to degenerative changes in the joint. So I think, as you easily can recognize, it's a mixture of many things. Now let's focus a little bit on the knee and go in more detail about joint structure. Clearly, it all starts with joint bleeding, and it all ends with many structural abnormalities. But what are all those structures? And I go through them one by one with you, just that you get an appreciation how complicated the joint is, and that the pain you are experiencing or symptoms you might be experiencing might be above and beyond just bleeding into the joint space. So we have the so-called synovial lining. This is this dotted line here, and it's just a one-cell layer that usually cannot be seen by any imaging, be it MRI or ultrasound. That thin it is in people who are not affected by any joint disease or hemophilia. It does one thing: it provides the joint with nutrients. It is well vascularized and gives nutrients, or nutrients penetrate here the joint fluid and then can reach the cartilage, which is here lining the femur and the tibia, and is very poor or not vascularized and needs these nutrients. The next layer I want to point out to you are these fat pads. Fat pads are cushions. They are here between the tendons and the bone to prevent friction. And they are also here infrapatellar. We call it Hoffer's fat pad, again to prevent friction from tendons and ligaments against the bone. Then we have the meniscus. These are sort of cartilage structures preventing, again, a cushion against bone. Then we have bursa. Bursa are little spaces that are under normal circumstances not fluid-filled or have very little fluid in it. And they, again, provide cushion for the patella and for other joint structures. And then finally, we have tendons and we have ligaments that are structures that make our bones move. So you can easily see, with this in mind, what can happen in consequence of joint bleeding to these structures. So for example, the fat pads here, in response to bleeding, can become very hypertrophic, and so does the synovium. What do I mean by that? Hypertrophic means proliferating with tissue growth and neovascularization. So it almost becomes like a tumor, a soft tissue mass. And that can cause impingements, for example, here infrapatellar or also suprapatellar. Cartilage will erode and almost look like moth-eaten, just like in osteoarthritis. These structures here become inflamed and fluid-filled, so we call that bursitis. And last but not least, tendons and ligaments can be easily become inflamed and irritated, and that predisposes them to tears and sprains. And then last but not least, like everyone else, meningocele tears. So come back to the conglomerate and compilation of finding. Hemophilic arthropathy is really poorly understood. How one gets from, let's say, a pristine joint and a few hemarthrosis to this burned out hemophilic joint with synovial hypertrophy, cartilage erosions, and joint destruction is really not clear. What is clear, though, is that probably hemoglobin released from red blood cells and therefore toxic iron is deposited in joints and joint tissue and causes the inflammation and new blood vessel formation. But how all these pathogenic processes hang together is not well understood. So in clinical practice, and trying to be a modern hemophilia provider, acute and chronic joint pains, I like to think like a bit of a mini orthopedist. If someone comes with joint swelling and pain, I don't just assume it's bleeding. I really do take a clinical look and be very pointed in terms of where's the pain. For instance, here at the lateral side, it could be have something to do with the iliotibial band, or here on top or below the patella, that could be something like jumper's knee or runner's knee. Not that you are all jumpers and runners, but the deformities of the arthropathy just might predispose you to exactly get those same symptoms and findings. And there are treatments for such. So that's to keep in mind. And then what do we do in the end once the clinical exam is finished to look at it with imaging and get a clearer picture? And so the ankle and the elbow are even more complicated. So the next question would be, how many joint bleeds can one experience without lasting damage? And we do not really know. Everyone is individual. In some patients, it may just take one bleed. In other patients, it may take a good number of bleeds. And that has been sort of shown up almost 10 years ago in a study conducted by Marilyn Manco-Johnson in Denver, where she took little children and randomized them into two cohorts, treating one cohort with prophylaxis and the other cohort just with episodic treatment upon reported bleeding. And so that in the United States established, no surprise, that prophylaxis can actually protect patients from long-lasting joint disease, or at least significantly reduce the joint damage. But what she also found when she pooled all the data, and what is really important to point out, is that you can see four groups of patients. One group here, demarcated by the yellow line, has a proportional increase in the degree of joint destruction, here exemplified by an MRI score, so simply by imaging and then applying a scoring system to what's found on the imaging, to the number of clinically evident index joint hemorrhages reported by the patient. So this line is clear. The more hemorrhages, the worse your joint outcome or your MRI score. Then you had a group of patients who apparently went for a threshold. They could have 5 to 10 bleeds without much damage, and then damage became proportional. And then you had two other groups of patients, this line in green here, where patients reported maybe 1 or 2 bleeds and had enormous MRI damage, whereas on the other hand, in this blue line, you can have patients who maybe have experienced 20 bleeds or such and they hardly had any damage. So how can that be explained? The short answer is we don't know, but it certainly raised a lot of questions. For example, the accuracy of our bleed diagnosis. Is there subclinical bleeding present, meaning like little children who had this really just a few bleeds reported, but lots of damage in the joint? Could they have experienced bleeding that they didn't even notice? And then are there genetic modifiers or other modifiers of joint disease that make it worse? And we don't know that, but that will be all subject of future research studies. So a lot of things we don't know, but what we do know is we have come a long way with clotting factor treatments. If you look to the left here at this little boy in Bangladesh who has no access to clotting factor and horrific joint disease, and you look over to the right, you have this little boy who lives in France, but he has access to clotting factor prophylaxis and rides his bike. You know, off the bat, that prophylaxis has done wonders in terms of preventing joint disease in childhood. But we don't know so much yet about long-term consequences, again, of subclinical bleeding or of just a few bleeds that now don't affect this little boy, but that might predispose this little boy to later arthropathy, and something that you are currently probably experiencing. So the bottom line is, even if prophylaxis is done well, it cannot entirely prevent arthropathy. And I think everyone understands that there comes an age in youth where adherence might become a problem, or sometimes the dose is skipped, or things of that sort. In clinical practice, not all prophylaxis will prevent all bleeding. In addition, the bleed threshold for arthropathy is unknown and seems really individual. And then it's been just shown that in adulthood, with adults who have actually joint disease, 20 to 40% of those joints suffer again from that subclinical bleeding, meaning you might have blood in the joint but not realize it. And what that does down the line to joint health, that is something we don't understand at all. And it appeared that the risk for this subclinical bleeding was associated with the severity of the arthropathy. So the worse off the joints, the more likely that there is bleeding inside and might propel that joint disease. So putting this all together, it's really time for personalized care and precision medicine. But how? So what can we do to prevent and treat? So clearly, prevention nowadays is first and foremost. Prevent bleeding equals prophylaxis with clotting factor. And then there is another important piece, which is moderate or low impact physical activity. So this talk is not about clotting factor replacement strategies. You have many choices, coming back to targeted therapy and personalized medicine, many choices. Plasma-derived factor, recombinant factor, short-acting factor, plus minus, long-acting clotting factors, alone or in combination. Dosing can be based on your personal half-life, on sporting activities, and on personal preference. So all of that can be discussed with your hemophilia physician. One important point to stress, though, is physical activity. And all I can say is move wisely. This type of activity, high-impact sports, is not even healthy for people without hemophilia, in my opinion. And of course, yoga is probably super boring. But there is some middle ground. There is something in between. So I call it Pilates, I call it swimming. And you might tell me again, well, but that is really boring. Walking, well, maybe, but this is really boring. Don't you have something else? And there are other things. If you go to the National Hemophilia Foundation website, this website is a sporting website, and it categorizes low, medium, and high impact sports, and you will find a lot, and hopefully there is something for you that's low or medium impact. What we have done here at the University of California in San Diego, we have initiated and launched the so-called Hemophilia Vertical Project, and it employs therapeutic climbing that's used in several other musculoskeletal disorders already. And we do that in cooperation or collaboration with the University Hospital and the Hemophilia Treatment Center in Munich. And the idea is to really improve strength, flexibility and coordination in these young patients. And we hope, and at least we have some hints with results from pilot studies, that it increases responsibility. You always are on a rope with several others, like here at an excursion in the Alps, and have to take care of yourself, hence be sure that you have infused clotting factor, and that relates to improved adherence to prophylaxis. This adherence, and then also the physical activity, that's really important, again, in terms of strength, flexibility, and coordination, will reduce bleed rates, improve joint outcomes, and trust building, because you interact with your peers, again, in sometimes dicey situations. So here you can see from my colleague in Munich, a patient before the start of the climbing program and after, in terms of range of motion, seems to be a real improvement. And this is the group in Munich, and this is the group in San Diego. And just to inject some humor, I think you can really see who lines up in Germany and who lines up in Southern California. What doesn't line up in Southern California? So here are some preliminary data with permission of Dr. Stemberger, my colleague in Munich. Rock climbing appears beneficial for joint health, and here she depicts the results of 9 patients and the annualized bleeding rate before 2012 and then in 2013 after they had finished several months of a climbing program. And you can see here is the bleeding rate in blue before, and here's the bleeding rate in red after. In this patient, nothing changed, but in many other patients, you can see a significant reduction. Here in hemophilia patient number 5, there is a disappearance, no more bleeding at all. Now in this patient, there is more bleeding than there was before. That's the only one, and we are not sure why. But again, in this patient, no more bleeding, and in the other patients, significant improvements. So that is encouraging, and we are now starting our own study, and hopefully will shed more light on beneficial effects of indoor climbing. So if you have a facility ready and available in your neighborhood, go. So how do we evaluate hemophilic joints in clinic? There are 3 different clinical scenarios. One is long-term follow-up of joint health from childhood into adulthood. What happens? One is being confronted with acute joint pains. And again, I would like to stress that not all is bleeding. Clearly, we want to know if hemarthrosis or bleeding is present, but there are also other reasons for pain. For example, synovitis comes back to the inflammation of this swollen synovium, tears, sprains, and a lot of other things happening in the joint. And then on the other hand, chronic joint pains that are just lingering and never really go away. And I would say here, don't exclude bleeding. But tendinosis, tendinitis, impingement syndromes, again, think about the swollen fat pad that can get underneath the patella and be squeezed. Ligament instabilities can contribute. And then there is long-term evaluation of joint status by various means of imaging and by functional or clinical scores. So we can evaluate the joint with the so-called clinical hemophilia joint health score. And I think probably many of you undergo that procedure once annually. And the physical therapy will put together parameters like swelling, crepitus, flexion, extension loss, atrophy in your muscles, and pain, and then come up with a score. And that sort of allows to follow you over the years and then maybe hopefully institute physical therapy measures like stretching or other things to slow that process. Then we have a very old-fashioned system. It's actually radiographic Pedersen scores. Dr. Pedersen was a physician or radiologist in Sweden who over 30 years ago, in lacking any other imaging technology at the time, put together a radiographic score that only consists of scoring of bony changes. It is insensitive to soft tissue and discovers late-stage disease only. So here you can, for example, see again a joint that is totally obliterated and moth-eaten cartilage. Actually, the cartilage is gone compared to a normal joint. Now, for modern hemophilia care, no one wants to wait anymore until one sees the first bony changes. One would like to see early changes to pickup changes that might still be modifiable in terms of interventions, just as more intense prophylaxis maybe. And therefore, with the advent of MRIs, MRI scores were devised in the mid-2000s. Now, the advantage of MRI is it discovers bony changes and is also sensitive to soft tissue changes. But the disadvantage is it's cumbersome in that only a limited number of joints can be started at a time, right? You have to lie an hour or more in an MRI scanner for one joint. For many patients, at least my patients, it sometimes becomes a problem because of pain and uncomfortable positions. And there's a limited frequency of assessment. You can't do it every few months. That has an alternative, though, and it's called musculoskeletal ultrasound that was recently introduced to the United States coming from Europe. And there is a new scoring system. It's called the Martinoli score. And the advantages of ultrasound are it is very sensitive to synovium, hence synovial hypertrophy. It is very good for loss of cartilage and disturbances of the subchondral surface. So for example, look at this knee, and this is the transducer position. We look here directly in the patellofemoral joint space. This is what you see. And that black line would be pristine, nice cartilage. And then scoring is devised based on cartilage loss, or here you see the moss-eaten subchondral surface, and then a common score is derived that can also be followed longitudinally. Now, the only disadvantage with that for any kind of provider, scoring is a bit subjective. So what we try to do here in San Diego is a future innovation, is actually taking the ultrasound and introducing more measurement and precision by just measuring structures such as cartilage thickness or synovial thickness, and follow that over the years. So for example, this would be a 21-year-old patient of mine with severe hemophilia, and his joints look very pristine. He has a Pedersen score and Stoney score of 0. But then looking with the ultrasound, you can see that here, again, looking into the patellofemoral joint space with the transducer, that this cartilage here already shows thinning compared to what is thought to be normal. This is actually my knee, and let's just for a moment assume it's normal. So already early changes that could not be picked up with a Pedersen score and are also not necessarily visible when examining the patient, even with a hemophilia joint health score. And then the same is true for synovial proliferation or hypertrophy. So the transducer here is held over the lateral gutter, but you see that synovial membrane that should just be one cell layer. And what you can see here is this darkish structure creeping out of the joint space, and that is already measurable synovial hypertrophy or borderline hypertrophy. Whereas you look at my knee, no such structure is visible. So now we come to acute joint pains and assessments. And here clearly, clinical exam and patient perception, this is what we used to go by, but how useful for hemophilic joints is such an assessment when we know now how complex pathology can be in the joint. Clearly, the distinction of bleed pain versus other joint pains is difficult. So what do we have at our disposition to be more precise? Well, imaging. It's just, again, the MRI takes too long. We can't do them frequently and all the time. CT scanning is not clinically useful in that it needs contrast, which can cause kidney damage, and it also exposes tissue to radiation, so one does not want to do it so frequently. And then x-rays again, but they are not sensitive to soft tissue changes or bleeding. So that brings musculoskeletal ultrasound, or in short, MUSCUS, into play, and also a function that we call power Doppler function, which is a very sensitive tool to visualize, and I will show you some pictures later, microcirculation in the synovium. So what we have done here or shown here in several research studies is truly that patient or physician perceived pain etiology is correct in less than half of painful episodes. And we did that by picking about 40 patients and have them call into our center for acute pains, and then we asked them to please tell us how they touch the pain. Do they think it's related to bleeding, to arthritis, or something else? They would tell us. We would bring them in the same day. We would clinically examine them, and then we would send them off for an ultrasound and derive a diagnosis. And turns out that bleeding was actually just present in about 1/3 of those joints, and the other joints had predominant findings that were different from bleeding and were treatable but with other means than clotting factor. So interestingly, though, the symptoms experienced, let's say swelling, warmth, or range of motion deficits were similar, whether there was bleeding or not. So they were rather non-specific. And then we found a number of other soft tissue abnormalities that could contribute to pain. So that is a blurry picture. So this is where MUSCAS really introduced diagnostic precision. It allowed now for guided treatment decisions. Those who had bleeding, treated with clotting factor and continued to treat until pain resolved. And those who didn't need clotting factor received other forms of treatment, for example, steroid injections or physical therapy or other measures for pain reduction. And then finally, the ultrasound allows to aspirate joints, especially in acute bleedings. In an acute bleeding situation, it might relieve pressure on the capsule and then also inject steroids or lidocaine. So diagnostic ultrasound is emerging rapidly in many other disciplines. It's new to hemophilia, but not to other disciplines. And this is just to introduce you to an editorial in the New England Journal of Medicine published last year, demonstrating that medical students outperformed cardiologists and internists' exam using tiny pocket devices for echocardiography or for abdominal ultrasound. And so these things are currently introduced into medical education. So technology is evolving fast. We're going now from MRI that weighs several tons to a laptop ultrasound as we use it in clinic to now pocket devices. And that is really important because it could start empower you if you would be taught, for example, at home, or data could be transmitted to the center to now distinguish in certain joints bleeding versus non-bleeding. So joint ultrasound, what can it do for you? We're switching a little gear now and sort of focus on this new modality. It's clearly state-of-the-art imaging, and it's used mainly in rheumatology and sports medicine, and it's used there for a decade and more. It allows truly easy bleed detection, and it has a high sensitivity for soft tissue abnormalities, believed to be higher, or there are good evidence to suggest that it is higher than with MRI. And this especially is true for synovium, for tendons and ligaments, and fluid identification as it relates to bleeding. It's very speedy. A diagnosis to give you bleeding or not could be made within 10 minutes. A more involved joint exam might take up to 20 minutes or half an hour, but that's max. And it's a point-of-care device. Fast diagnosis facilitates goal-directed interventions, and that is really the goal. So all I can say is embrace the evolution of medicine. So what does a joint bleed look like? So with the transducer, we push into the lateral gutter of the knee here, and this is what it looks like on video. This is a bleeding knee, and you can see what I call here a complex effusion. The black areas here are an effusion, and you see all these little speckles and fibrin strands that get displaced with sonopalpation. So that is clearly what we call a complex effusion, and most likely bleeding, as opposed to something that we call a simple effusion and non-bleeding, and we'll get to that in a minute. So I think you can clearly see the advantage of the MUSCAS is fast and easy bleed detection, and the distinction of non-bloody, simple, versus bloody complex effusions. So both of those effusion types are compressible with the transducer, but in a bloody or complex effusion, you see displaceable speckles, fibrin strands, or let's say other material. And so what do I mean by that? So look at here, two knee joints with pains and effusions. This one is a patient with rheumatoid arthritis, and we look again into that lateral gutter, and you see a what we call an anechoic or very hypoechoic black effusion. And this effusion is not bloody because it's hypoechoic and black without speckles, but you see here lots of tissue that is perfused. These little dots are actually power Doppler function that one can switch on, and it shows then the abnormal blood flow in the synovium. So this patient with rheumatoid arthritis has a highly inflamed joint, but the joint fluid is not bloody, it's serous and clear. Whereas here in this patient of mine with severe hemophilia, you see a complex effusion. You again in the lateral gutter see the, this time more hypoechoic speckled appearance of the fluid, and here we have fat pattern synovium with some specks of red indicating vascular perfusion, but not necessarily overperfused or inflamed. So let's go to some cases. How can ultrasound come in handy in terms of point of care? So this is a patient with lower extremity bleeding. He tripped and had a injury with the fall, and he came one evening into our center. He did not want to go to the emergency room, understandably, and I think he would have not needed the ultrasound necessarily to show that he has bleeding, but I demonstrated to you regardless. So we go again into that patellofemoral joint space with the transducer, and what you can see here is this wide joint space full of blood compared to the normal pristine joint space. So he has hemophilic with a wide joint space. But in addition, what the ultrasound could do here, rule out something we call compartment syndrome. You can imagine that all this bleeding leads to really tight muscular edematous findings that could compress blood flow. And so here with the Doppler function in this patient, we could show that there is good blood flow in the tibial artery and the dorsalis pedis artery, and so that really saved him a trip to the emergency room, and we started him on clotting factor treatment. So then he got better, and several weeks after the bleed resolved, he still has lots of pain on the medial side of his knee, and he points to where the area of the meniscus is, and so we examine his knee with the ultrasound, and this would be the meniscus, and you can see here these black sort of cystic structures and ruptured areas that really look like meniscal tears and tears of the medial collateral ligament. And then when we switched on the power Doppler function in this area, now you can see these pulsating vascular signals that are abnormal and indicate high inflammation. Those signals would not be present under normal circumstances. So now, is an MRI necessary? I mean, ultrasound cannot show everything, and I would say yes, once the patient is able to lie for 1 to 2 hours, because the ultrasound cannot assess deep structures in the joint, such as ACL tears and other. But what it did in that patient, it allowed us to determine the intensity and length of the clotting factor treatment. It allowed also for an ultrasound-guided joint aspiration, just to alleviate the acute pain. And then based on our ultrasound findings, we could actually institute physical therapy that was appropriate for this type of injury rather than guessing. So this is another case, a 33-year-old patient of mine with severe hemophilia A, and he comes with chronic ankle pain, and we actually diagnosed Achilles tendinosis. But what the patient told me when he came to clinic, he said, I have increasing pain involving my left heel for 6 weeks or more. And that it coincided with his new job as a pizza delivery man. And he said, Dr. V, I think I'm bleeding all the time now because I'm just on my feet all day. And I started to infuse clotting factor daily. So I said, let's take a look. And you see me here scanning the Achilles tendon of this young man. And this is his right Achilles tendon in comparison. That was the non-painful tendon. And you see regular fibers here. Underneath is so-called Cargus fat pad, and here would be his heel, calcaneus. And then the painful Achilles tendon is thickened with a disrupted fibrous pattern, so something that one would clearly diagnose as tendinosis. Now, why is that? We look here, go down a little further on the Achilles tendon and come to the links of the heel of the calcaneus and the Achilles tendon insertion. And you can see that in his painful heel, he has actually quite a bit of a bone spur with irregular fibers at the insertion site. And that was treatable, and curiously enough, this is treatable with just physical therapy, even bone spurs, because bones remodeling. And after 6 weeks of his physical therapy exercises and specific stretching exercises, these findings and the pain resolved. So these are two examples to lead you into the modern world of hemophilia treatments. There are really many tools to personalize joint care. Point of imaging is just one. But you also have, as we already alluded to, individualized prophylaxis based on your personal half-life or in combination of different short and prolonged half-life products. There is appropriate athletic activity to promote your joint health. For example, Hemophilia vertical, our patients really like the program, so I'm bringing it up again. Then there are novel approaches to synovectomy if there is intractable bleeding, despite the fact that you are infusing enough factor, rather than going to radioablation or other measures. There's now some synovial embolization, and I will show you a picture in a moment. Then there are joint injections and aspirations, borrowed from the world of osteoarthritis and rheumatoid arthritis. And then there are lots of novel orthopedic interventions out. We are all familiar with knee replacement, but now there are centers that do perform ankle and elbow replacements and bone and cartilage grafting. And that latter is sort of a precursor of fusion. So one does not have to necessarily go right away to fusion. One can try bone and cartilage grafting first. So synovial embolization, what is that? That is actually a microcatheter that's tunneled through the femoral artery, that's tunneled into areas of vascularity in the synovium. And you can see here this patient with intractable bleeding despite high factor VIII levels. And so you see all the vascularity here in the joint space. And here, this is captured at the same time with the ultrasound and power Doppler signals showing this large, patchy, inflamed vessel signals. And then a dye, or first a dye, and then either particles or a glue is injected into those vessels here. The radiologist or interventional radiologist can take a targeted approach and sort of tunnel microcatheters into these arteries. And then this is after the glue is injected. These vessels are ablated, and not only did the bleeding stop, but you can see that the vascularity has disappeared. Another novel way to address joint pains, especially in inflammatory disease, are these steroid or lidocaine injections under ultrasound guidance. We perform them now quite frequently in clinic. So this would be an example of an inflamed infrapatellar Hoffa's fat pad. If you remember the clinical picture where we showed the structural knee. So here is this fat pad, usually a cushion between the patella and the femur and the tibia, but it can get quite enlarged and painful in inflammatory situations, as you can see here, lots of vessels. But after the steroid injection, that vascularity normalizes and pain relief ensues. And that is a similar picture here in a patient with bad elbow pain and inflammation in the olecranon fat pad. And after injection, that vascularity gets much better, and so does the pain. So, in summary, coming to the end now, pain in hemophilic joints can have multiple reasons. Modern hemophilia care requires point-of-care imaging to assist in diagnosis and management of hemophilic joints. Joint care is really a joint team approach, and that also requires patient participation to personalize strategy for optimal outcomes. No size fits all. It's really not just clotting factor. Think beyond. And as a patient, help move your care to the next level. So life is inspiration and a journey, I would say, from blood films to joint images. So I'm with you in that journey. You see me here more than 10 years ago as a hematologist looking at blood smears through microscopes. And now I'm looking at ultrasounds and diagnose help with the diagnosis of joint bleeds and other musculoskeletal syndromes. So that is the end. My patients never let me off the hook. Questions, discussions, and thank you very much.
Thank you so much. We do have a question. Do you know much about the success of ankle replacements or grafting in hemophilia patients?
Yeah, so I don't know that I know much, but I do know of a center that does those and has done ankle replacements in over 400 patients, not hemophilia, just regular 400 patients, of which a significant number, though, were hemophilia patients. And so outcomes seem to be reasonable, and that's definitely something to think about because it does maintain joint functionality rather than fusing the joint in a fixed position.
Great, thank you. Anybody else have any other questions? Please submit them into the question box at the bottom of your control panel. Just give everyone a moment if they are typing in a question.
Sure.
Thank you. All right, we have a few more. What center is doing the ankle replacements and grafting?
Sorry, can you repeat that question?
Sure. Which center is doing the ankle replacements and grafting?
Yeah, University of Georgetown. And I'm happy to provide more information. If that patient would like to send me an email, I can sort this out with them.
Great. We'll send a follow-up email in the next day or so. Do you mind if we share your email address?
This would be fine.
Okay.
So one way to address this maybe is if patients have questions, they might also field them to you because several patients might have the same question. They could be summarized, and I can devise a summary response just as a thought.
Okay, great. We could do that. So the next question is, I have had 3 bleeds in my knee. Can it recover to full functionality?
How long ago were those bleeds? Were they just recent or experienced when the patient was young and is now older?
2010, he says.
And how much functional impairment is there now?
Give him a minute to type.
Sure.
Full movement, but it gets sore.
Yeah. So I think this is good. So at least there's full movement. I think it would be good to get a diagnosis to see why it gets sore. Again, is it some tendon or ligament instability? Is it synovial hypertrophy? Is there cartilage damage involved? Excuse me. Because physical therapy can truly do wonders, targeted physical therapy, in order to improve joint strength, recommend appropriate exercises, and with that, things might get better.
Okay. So the next question is, I thought aspirations were bad.
No, I don't think that is quite clear cut. I mean, they might have been bad many, many decades ago when there was no clotting factor. available. So one would stick a needle, especially not ultrasound guided, just blindly into a knee and aspirate, because easily conceivable that structures get penetrated, or vessels get penetrated, and then more bleeding ensues, especially if there's no clotting factor on board. But that should not happen under ultrasound guidance, and especially if clotting factor is on board or has been given prior to the injection. I think what this is doing is, though, aspirating blood that can be aspirated from the joint, thereby alleviating pressure and getting blood out that, the longer it lingers, probably does more damage.
The next question is, can you talk about cartilage grafting and how it works?
Yeah, so that is done here at in San Diego at Scripps. We're working together with a physician there. He takes either cartilage from deceased people or bone from areas of the patient, for example, the hip, and then this gets sort of layered into areas where normal cartilage should have been in the first place, but is maybe eaten away or destroyed. And then the cartilage has mechanisms to sort of grow into that space and make that space smoother. It could be either cartilage or sort of a bit of a bony replacement. It doesn't work in all patients, though. If the arthropathy is very severe and progressed, let's come back to the old Pedersen score of, let's say, over 8. That's my experience. Then it's hard to do reparative measures. But anything before that, sort of on the brink of getting worse, that might be an alternative to fusion.
Okay, thank you. The next question is, I live in the New York City area and have struggled to find an orthopedic who understands how to handle hemophilia ankle conditions. Any recommendations on how we can find someone or educate our orthopedic on hemophilia joints?
Yeah, there is a physician. He is called Dr. Gilbert, and he is the inventor of the Gilbert score. In case the patient has heard of this score, he can easily Google it. Gilbert, Gilbert, and he is an orthopedic surgeon in the New York area. It escapes me exactly at which hospital, but he's there, and I just talked to him at the World Federation Musculoskeletal meeting, and he's still seeing patients. So that might be a route to pursue.
Great, thank you. She says thanks. Any other questions? Well, great. So we will provide a follow-up email, and I think the route we'll go will just, if anyone has any questions, they can send them to the reply of that email, and then we can forward any questions over to you. Dr. Rondra,
just fine.
Great. All right. Well, thank you so much for your presentation and for being here. And for everyone on the line as well, this webinar is being recorded. And the next couple of days, it will be up on HFA's YouTube channel. So if you missed a portion of it or would like to watch it again, you are welcome to do so. So thanks, everyone. Have a wonderful night, and we'll see you all soon.
Thank you, everyone, for your attention and the opportunity to talk to you and share information.
Great. Thanks so much. Take care.
Take care. Bye-bye.
Bye.